Welcome, everybody. My name is Sue Wong, and I'd like to welcome you to the session, Bridging Gaps in Hepatitis B Care and Treatment, bringing science and affected communities together. My name is Sue Wong, Program Chair of the World Hepatitis Summit, and we're especially delighted to bring this session to you as we believe it's very important and timely for us to be discussing care and treatment gaps and how we can bring science and affected communities together. And I want to introduce my co-chair.
This is Philippa Easterbrook from the Global Hepatitis Program, and looking forward to this really exciting session.
So I just want to review our learning objectives real quick. This session will look at recognizing gaps in hepatitis B care and treatment between lower, middle, and high-income countries. We will hear patient experiences in accessing hepatitis B care and treatment around the world. We will explore how affected communities can intersect with science to improve care with a look back on the HIV experience. And finally, we will discuss opportunities for guideline adaptability in various settings, patient preferences and values, and the role of simplified and decentralized care to bridge current gaps. So with no further ado, I would like to welcome Dr. Halmakel Desalin Makonnen from St. Paul's Hospital Millennium Medical College in Ethiopia to share his thoughts on low-income gaps in hepatitis B care and treatment in Ethiopia and other countries. Go ahead.
Thank you for the World Hepatitis Summit to give me this chance to present on the hepatitis B virus treatment gaps in low-income setting. I am Dr. Halmakel Desalin from Ethiopia, from St. Paul Hospital. I try to show that the gaps in the cascade of care in the hepatitis B virus treatment program. So this is my, this is where I come from. So Ethiopia is one of the Eastern African countries, which is the second populous country in Africa, second to Nigeria, with the estimated hepatitis B virus prevalence of 9.4. If you assume that of 109 million people in 2018, this could mean more than 10 million people infected with the hepatitis B virus. So this is the distribution of the different hepatitis B virus based on those studies. We can see some areas in the northeastern part of Ethiopia having a higher prevalence of around 28.8%. This could be like 1 in 3 individuals could have the virus. And let's see the other parts having the prevalence of 10.7, 10.8. You can see 13.4 in the western part of the country. And the gaps or knowledge is very important to know the mode of transmission so that we can also recommend some preventive methods in the transmission and the prevention of transmission aspects. So some evidence in the mode of transmission, even though there is a gap in the knowledge, some evidence we have seen that intimate contact among toddlers and previous meta-analysis has shown risky practices which are still practiced in some parts of the country, including local practices and also increasing tattoo places in the cities, which are not licensed, which are not actually well controlled, could be one important part of the risky practices. Looking at the highest prevalence areas, we have seen that female genital mutilation in these areas could reach up to 91 and 99%. This needs further awareness and prevention means, and we have also seen low institutional deliveries, which is around 14% in areas of high prevalence from the data. The other gaps, if we classify them based on the vaccination, national policy for adult hepatitis B vaccination is non-existing in Ethiopia, and universal birth dose vaccination is not available. And diagnosis and therapy, this vaccination is mainly on the birth dose vaccination. Otherwise, the EPI program has been ongoing for the last more than 8 years. When you say diagnosis and therapy, still the patient out-of-pocket payment for diagnosis and drug therapy and no system to support them, so that viral load tests are still expensive and they are sent abroad for majority of the individuals. And at the individual level, we see a lot of discrimination and there is no national laws that protect people infected with hepatitis B, especially in the workplaces. And also, when we translate this to African setup, only 2% of Africans living with chronic Hep B receive a diagnosis and 0.1% receive treatment. This is the same true in Ethiopia and other low-income countries. Less than 1% are diagnosed and probably 0.1% are on treatment. This compared to the developed countries which could come with the political will, also 18 to 19% versus 2 to 3% in low-income countries, and only about 11% of newborn babies receive the birth dose vaccination. So there is also a research gap. We have seen there is lack of longitudinal cohort studies in Sub-Saharan Africa. Probably there are only 2 studies that we can find from the searches in the PubMed. Cost effectiveness analysis, even though we know that it's important, so that to also give an input to the policymakers if we have a wide-scale screening, linkage to care treatment, and follow-up as one part of a study. Doing this versus future management of complications like end-stage liver disease, hepatocellular cancer, mortality, which are not available in low-income settings. Such studies might influence those working at the ministry of health or policymaker level, or then trying to invest on that could be one important thing that we recommend as a research gap. And novel risk factors for HCV development are important. It's like hepatitis B is one important cause, but hepatitis B patients are also coming with advanced stage at younger age, with advanced hepatocellular cancer, with metastasis, with tumor thrombus, and early identification of patients with hepatitis B is very important because of this. They're present with an advanced stage, and so early identification of cases and identifying those individuals that could work as synergy with Hep B for poor outcomes are important. So we have many challenges, but we can start poor awareness, attitude, patient present medical care with advanced disease after initial herbal or traditional treatment. Patients with Hep B, with jaundice, literally they go to initial herbal medication before they seek medical advice. So it becomes late. And the other non-invasive markers are very important. We need to rely on point of care tests and also non-invasive markers which are dependent on laboratory tests are important, because still for the last like we are almost a decade to the 2030 elimination. If you rely on those advanced tests, it will not be feasible. So we recommend to have a need for locally relevant treatment criteria, and diagnostic capacities are important. So we recommend screening strategies to identify cases as early as possible. And guidelines, we have seen it had been adopted from EASL or from the Europeans, and also even the WHO's are difficult. We have shown different studies that they miss main patient need of treatment. And we recommend like management depend on liver biopsy are not feasible in our setup. Nucleic acid-based tests we have seen for a long period of time, they are not feasible for wide scale and also for elimination strategies. So we rather recommend alternative point of care tests, and like WHO and others should see African data, should support African data that are working to have non-invasive tests for cutoffs for Africans. So it should depend on that, and African cutoff points should be adopted for us and for and based on studies for other low-income setting. Integrated programs to leverage resources like HIV and TB. We have tried to use the HIV models to integrate with the HIV with the hepatitis B treatment in our pilot project that we have started. So political will is a basic and commitment, and so the government actually needs some support. There are no partners supporting the Ministry of Health in the hepatitis B, so support is very important here. Integration to distinct programs should be well planned and systematic. As our research group, ETH NORHEP, with this Ethio-Norwegian hepatitis group, we have tried to implement pilot programs. It has started in February 2015, and currently we have scaled it up to 4 more sites. But this is the tip of the iceberg compared to this burden. In summary, implementation programs in prevention, birth dose implementation, screening strategies should be improved, and we need to paint and to fund and support locally adopted treatment guidelines in general for low-income setting. With this, I would like to thank the organizers for this, and I'm open for further discussion, and thank you so much for World Hepatitis Summit organization.
Hello, thank you very much, Dr. Haile Missel. I would now like to turn to Dr. Fushan Cui, who is from the Peking University in China and who was a former colleague of ours in the Global Hepatitis Program at headquarters, and who will be speaking on bridging the gaps in hepatitis B care and treatment in China from a middle-income perspective. Thank you.
Good morning, good afternoon, good evening. This is Fu Qiang from Peking University. Thanks for inviting me to be here to present the hepatitis B care treatment in China. As you may know, China has a bigger chronic hepatitis B infection population in the world. So the general prevalence is around the 6%. But due to the vaccination policy, the prevalence among children under 5 is estimated to be 0.2 to 0.3. So the chronic hepatitis infection is due to the large, due to the pars infection. So you can see the figures here. There are 86 million population was living hepatitis infection. 900,000 developed into cirrhosis annually, and 300,000 developed HCC annually. So this accounts for the 47% global new HCC and 47 global HCC deaths. And the National State Council has issued the Healthy
Consejo
2080,
Estatal para asegurar que haya una
2019-2030.
iniciativa
And also
de
government
China saludable 2019-2030 y también
has
un
mentioned
informe del
improving the
trabajo del
prevention and
gobierno
treatment service for hepatitis
que
B
muestra que hay
and
una
other infectious
mejoría
disease.
en
And
la
this is good
prevención
news.
y servicios de
And
tratamiento
the
para
Ministry of
hepatitis y otras
Health
enfermedades infecciosas.
issued an
Y
action
el
plan
Ministerio
for
de Salud, junto
prevention,
con
care,
otros
and treatment
ministerios,
of viral
tienen un
hepatitis
plan de
in
acción para la prevención,
2017.
atención y
And
tratamiento de la
this
hepatitis viral desde el
experts need
2017.
to be
Y esto es
updated
parte
in the next years.
esto va a
And
ser actualizado en
also,
los próximos
the
años. Y
Ministry of
también
Health issued
hay
the
unas
mother to child transmitted
directrices
guidelines
publicadas por
together
el
with
Ministerio de
the HIV
Salud
and syphilis.
para incluir las hepatitis virales
So,
en la atención
among the
para la prevención de la transmisión.
national
Perdón, hay
hepatitis
unas guías también para
infections,
prevención de la transmisión
only
materno-infantil. Esta es nuestra
47
cascada para
will
hepatitis
know
B.
the status, and
Podemos
less than
ver
20%
que
were diagnosed,
hay menos de
and only
20% de
more than
personas
2%
diagnosticadas y de
receive the
estas
treatment.
apenas
So the testing and
2.5%
treatment
reciben
for
tratamiento. Así que
chronic hepatitis B
el
is very, very
diagnóstico y
low.
tratamiento para la
The
hepatitis
good news
crónica,
is
la hepatitis B crónica
the
es muy
antibody
bajo.
treatment
Las
of hepatitis in China, the drug price dropped from $220 per month to $75 per month since 2016, and also dropped another 96%, only to $1 per month since 2019. So this makes the drugs available for many other chronic infections, and this will be, improved the accessibility for many other chronic hepatitis infections. And the study shows from the research in China shows that population, the early infection, the higher and the better impact. So the decline in hepatitis-related deaths over time, if you start from 2021, there will be, 70% of reduction. But if you start from 2026, there will be only 14% reduction. And from 2031, only 12% reduction, the deaths. So this means that we need the early testing and treatment policy. And for the effectiveness, it seems that universal screening is effective regarding of the issue here. And cost-effective for testing among the 18 to 70 years starting 2021 is the most cost-effective, and the robust study finding can be generalized to China as a nation or applied individually to small region and province. The delay screening implementing reduce overall cost effectiveness, and downstream links to care are needed to further reduce mortality and achieve the 2030 target. If you look at the policy for prevention and treatment, so only prevention, it can reduce the incident but cannot reduce the mortality. So only for prevention, compared with 2015, there is only, the reduction in the incident, but the mortality is still increasing. So only the for prevention plus case finding for 80% of the diagnosis rate and treat all of the eligibles. This will bring 40% reduction on mortality. So the challenge is there. We have developed national policy to support treatment. We have improved the medicine affordability and suppliers, drug price drop. First-line medicine has been listed in national insurance. And we established a working committee promoting the elimination of hepatitis B in Chinese Preventive Medicine Medical Association. I'm the chair of this committee. And the province already started a pilot program to eliminate viral hepatitis. That's very good news. And other provinces will follow. The challenge is the current of testing and treatment services limited and progress is slower. Lack of effective information system to monitor and understand the progress. This is the challenges in China and in many other countries. So this is some information from China, and thanks for listening. I will be happy to receive any questions. Thank you.
Thank you. We're going to be taking all the questions at the end. Thank you so much, Fushan. And I would now like to move on to the high-income perspective, which will be presented by Dr. Nora Torrent from the University of Southern California. Nora, thank you.
Thank you very much for the invitation. I'm really excited to be here, and I really want to thank the organizers for the opportunity. So I'll try to address issues in a high-income country, and I'm going to focus on primarily US data with some data from Canada as well. So first, in considering the burden of disease in the US and in Canada, it's largely a disease among the foreign-born. So shown here are epidemiological data that have provided us with estimates of disease burden, shown on the left. And what you can see is that it's estimated that about 1.89 million individuals in the United States are affected, with the upper bound of that confidence interval being as many as 2.4 million, but that 80% of those are among the foreign-born. And shown on the right is where are those foreign-born from? And you can see that it's primarily individuals from the Asia region, but that we also have representation from the Americas and as well as Africa. And that over time, from 2009 to 2018, there's been an 11% increase, saying that this continues to be our primary source for chronic hepatitis B in the United States. Now, the main issue is about making the diagnosis. So shown here is data from NHANES. So NHANES is a survey of the general adult population in the United States, non-institutionalized. And what you can see is, based on this estimate, they did screening of all individuals, and they identified 1.3 million individuals who were affected. But remarkably, when they asked those individuals if they were aware of their infection, only 34% were aware of their infection, and only 28% had ever been treated. And when they looked at the factors associated with whether they reported awareness, you can see that being a US citizen, being of college education or higher, or having an abnormal ALT were the factors. Similar data comes from Canada. So Canada has a public health system, so they have the ability, so insurance is not an issue in terms of getting access. Similar data here. You can see that in Canada, 71% of their prevalent infections are estimated to be among foreign-born, in this case, immigrants. And as shown here, you can see that again, about 50% in Canada are from Southeast Asia or the Western Pacific. But very similar to US data, you can see that 31% of those that were estimated to be infected were actually aware of their infection. 18% were engaged in HBV care. And in this instance, only 7% of patients had treatment initiated. But interestingly, in this study, they showed that immigrants were more likely to actually be engaged in care and to have initiated treatment than long-term residents of Ontario, Canada. So this sort of speaks to the important issue of screening, and screening particularly in immigrant-rich communities. And I think looking at what the potential gaps are in terms of our ability to do that screening is important. Not only screening for hepatitis B, but also the next, one of the important additional steps in care, which is HCC screening. So this is a study of providers from immigrant-rich communities in New York City, which serve mostly Asians and Africans. And of the 109 respondents, 73% of them did report routinely screening immigrant patients for hepatitis B, but only 68% recommended screening for HCC. But importantly, when they were asked what the barriers were in terms of them offering treatment, you can see that lack of clear guidance around treatments was cited as the most common barrier, but other things include competing health priorities, as well as time constraints. So in terms of capacity, in terms of doing appropriate care of patients, clearly we have to be aware of the gaps related to provider knowledge and their competing risks in terms of other things they're doing in practice. Now, once the diagnosis is made, we know that patients with chronic hepatitis B need longitudinal follow-up. So studies have also looked at whether individuals once diagnosed are receiving adequate ongoing evaluation. And this is particularly important for individuals who ultimately need to be determined whether they are eligible for treatment, because we know that that's dependent upon serial values of ALT and HBV DNA. So in this large US claims data set, you can see that of the nearly over 12,000 individuals that were identified as having chronic hepatitis B, only 72% had an adequate evaluation at any time, and only 51% had adequate testing, meaning at least one ALT and HBV DNA in the last 12 months. And when they looked at what the key predictors of having an adequate evaluation were, you can see that Asians compared to other racial ethnic groups had higher rates of having evaluations, and so too were individuals who saw a specialist, a GI or ID provider. And then finally, it sort of touches on the issue of treatment. So we know that our current treatment guidelines for chronic hepatitis B in the United States and in other high-income countries are largely based upon AASLD or EASL guidance, which rely on ALT, HBV DNA level, and staging of disease. And I've summarized them here in this table. And what you can see is the primary criteria are having a HBV DNA level in e-antigen positive patients over 20,000, in e-antigen negative patients over 2,000. The thresholds in terms of ALT values for AASLD, they use greater than 2 times upper limit of normal. EASL uses a somewhat lower threshold of greater than upper limit of normal. And then anyone who has cirrhosis is also recommended to be treated. But obviously, to initiate treatment, you have to have serial values in order to be able to make these decisions. So how are we doing in a high-income country such as the US? Well, the short answer is we are not doing as well as we'd like. And so here is a very nice study, again, using that claims data of over 12,000 individuals. And you can see that of the 100% that have chronic hepatitis B and those that met criteria to be treated, only 60 to 65% of them were treated at any time. And in a second cohort shown on the right here, in which they did the same thing, they looked at a health system and were identifying those that met eligibility criteria. The first and important thing was they identified that actually almost 1/4 of the patients didn't have sufficient information to be able to determine the treatment eligibility. Again, not getting ALT or HBV DNA levels that allow that to be made. And then of those that did have sufficient data and were deemed to be treatment eligible by AASLD criteria, they found that only 67% were treated, 1/3 were untreated. Letting us some very consistent data between these two studies that about 1/3 of all of our treatment eligible patients, even by current guidelines, are not being treated. And one of the key areas I think that's emerged out of such studies is that there's also a large proportion of patients that have so-called indeterminate or gray zone values. And what do we mean by that? We mean it's individuals who ALT levels or HBV DNA levels don't quite meet the thresholds to initiate treatment per current guidance. And in this particular study, they showed that almost 40% of patients fall into this gray zone of patients. So they're not clearly inactive, they're not clearly active. So they sort of are in that in-between phase where it's not clear whether you should treat or not. And importantly, when you follow these patients, even for periods of time up to 5 years, you can see that fully three-quarters of them still remain indeterminate. So it means that over long periods of time, people are sort of in this zone where we're not sure whether to treat or not. And I think that that's a significant barrier in terms of getting people to treatment who potentially might benefit from it, highlighting this possibility that simplification of our treatment guidelines could improve our rates of treatment and might help us to address that 1/3 that is not getting treatment that is eligible. Okay, so just to summarize the potential challenges and solutions in high-income countries, in terms of screening, lack of awareness is still an issue for us. And so we're looking to a broader screening mandate, and potentially screening all adults at least once might be one preferred way to do it rather than our current criteria, which are based on country of origin and risk. In terms of monitoring, there's a lack of appropriate monitoring and HCC surveillance here. I think the emphasis has to be on provider education, especially at the primary care level. Because we need to broaden our capacity to do treatment. It can't all be done by specialists, and maybe a focus on providers serving the foreign-born is important. And then finally, for treatment, I think the lack of treatment among eligible patients really speaks to the need to simplify the way we approach treatment so that it's not so challenging to make a decision. And perhaps the greatest gains to be made here are in addressing this indeterminate treatment eligible group. Thanks very much.
For sharing the experience of the US and high-income countries. It's clear there's still many gaps in diagnosis, care, and treatment. So we're looking forward to the discussion following this. I want to first introduce the next speaker, Danjuma Ada, who is the president of the World Hepatitis Alliance, and he will be sharing on perspectives of people living with hepatitis B on access to care and treatment. Go ahead, Danjuma.
Right, thank you. I would like to say thank you for giving the patient community the opportunity to actually share the perspective of the patients in terms of access to care. And I would like to say that over time, patients have always felt this sense of being neglected and sense of not being carried along in the healthcare system, and that really has been a very strong factor in limiting people's access to care. So, and the hepatitis B prevalence or epidemiology is quite diverse, and all over the world, in fact, the prevalence of hepatitis B is highest among marginalized, in some places, minority ethnic groups. If you go to high-income countries, you discover that the populations that are mostly affected by hepatitis B are the underserved, marginalized populations. But if you come to low and middle-income countries, you would see a kind of different perspective. It's more generalized, but then there are still a lot of issues that affect the patient's access to care. I'm happy with the presentation by Dr. Nora, which rightly captures some of the perspective of patients. And like one of the first things I mentioned is the self-stigma. So the patient in most of, okay, I'm speaking as a person living with hepatitis B. And then I know what it took for me to really overcome the first fear and the challenge of, okay, I have this virus and it has the potential to end my life. And the most information patients have is that you have hepatitis, you're a dead person. So it's like it's a death sentence for almost every patient. So that lack of information, accurate information, kind of deters many patients in even accessing care. Some people even give up before even accessing the care. And I would say the complex and scientific language doesn't really help also. And especially patients that are living in areas where there's maybe lack of information. If you discover most majority of the guidelines are really a lot of top-notch scientific, very complex languages that are not really, should I say, simplified in a very simple term for people to really understand. So that is also could be sometimes a barrier because the patient doesn't really, and the healthcare provider might not really have time to educate the patient or to even tell the person what he or she needs to know. So that really is a strong barrier for most patients in accessing care. And I'll also say that the diversity in hepatitis B also brings about a lot of inequalities, a lot of disparities, poverty. The current guidelines where, for example, I'll give it in Nigeria, where a hepatitis B viral load costs about $80. You're looking at patients that are living under $1 per day. So the person is thinking about, and the patient have the competing needs for, let's say, rent, feeding, children's education. So you don't expect that person to cough out $80 for just one diagnostic test.
Every 3 months.
So it's really, and it's out of pocket. Majority of patients in Africa and mostly more low-income countries live out of pocket. I mean, the healthcare they do out of pocket. There's no health insurance. So the cost of those diagnoses are now, for most patients, they think about long-term, there's no cure. So the person begins to think about how much he or she is going to spend monthly, with competing needs, with the poverty, with the high rate of economic problems. So it becomes really, really a problem for most people to access care. And then, so the cost of testing, and majority of patients live in areas that cannot access easy testing. I'll still give an example in Africa and in Nigeria. Most diagnostic platforms are located in specialized areas, very far off from where patients live. And most secondary and primary healthcare centers do not really have quality diagnostic platforms or even treatment for patients. So the patient is thinking about transportation to the specialized centers where he or she will access care, and the cost of transport, the cost of going, and then the patient sample is taken. It takes like 1 month for just the PCR viral load result before it is released. Turnaround time delays for like 1 month or 2 months. And the patient will always seek for alternative. Majority of our patients will always seek for alternative self-help. They go to the orthodox traditional healers who promises an immediate cure for their conditions. So low turnaround is really a big deterrent for most patients accessing care, because most viral load platforms in Africa use PCR and they take like more than 30, 60 days before results come out. And before then, the patient is lost. The patient never comes back, and he goes off for self-help or self-care. So majority of patients, and we see that every day. I have a lot of emails, patients sending emails. They keep telling you they cannot afford the cost of the DAAs. In Africa, in Nigeria, tenofovir goes for more than, I think, $30 thereabout for a bottle for a month's treatment. So poverty still comes back to the whole thing. So lack of information, and then I think maybe patients don't really have that sense of belonging with maybe the clinicians to see themselves as equal partners in the context of co-creation. Patients don't see that that importance given to them, and the patient feels he's just like a chest in the pound. He's just been as like an experiment. So the healthcare provider doesn't give that patient the sense of belonging, that you are important. So you are important. You are an equal partner in the healthcare system. And so in most cases, because of the healthcare ratio to patients, in fact, within 2 minutes, the patient sees the doctor has already made the prescription, the patient is going. There's no proper engagement with the patient. So the patient doesn't really feel that sense of belonging. And so the patient always seek for alternative care, where in the community, they promise them all sorts of cures and everything. So these are a lot of factors. So it starts with the limiting thought by the patient. First of all, the self-stigma. The person gives up and thinks that I give an example with myself. It wasn't easy initially when I was diagnosed. I had to really do a lot of search and studies to really understand that it wasn't the end of my life. It wasn't the end of everything. There was still hope and there's still effective treatment. So, but then the systems, the healthcare systems, you discover the patient comes to the hospital, multiple barriers, registration, administrative, before he goes to do the test, before he sees the clinician, the whole day is gone. So these are all issues that need to be addressed. Multiple systems in health, multiple barriers in the healthcare system, and the cost of treatment, the cost of diagnostics. They are in centralized areas, specialized areas. Majority of the patients live in rural communities, and then the lack of maybe clear, simple explanation, languages, and even in guidelines or even discussion between the patient and the healthcare worker. I think these are things that needs to be considered. So the patient should be seen as an equal partner in a co-creation manner, and not to be seen as just, the clinician should not see the patient as just you're treating the virus and not the person. So look at the individual as an important person that is being treated. So not just the virus, not just the disease. So thank you so much for this opportunity, and I'm happy to share this. Thanks a lot.
Great. Thank you, Danjuma. Really important perspective, especially coming from Africa. So next, I'm very pleased to introduce Mark Harrington, who is well known in the HIV community and has done phenomenal work in terms of bridging science and community and the affected community. And we're looking forward to Mark sharing the look back at HIV treatment evolution and the involvement of people living with HIV. Go ahead, Mark. Oh, actually, I'm going to share. Hold on, I'm going to share your slides. Okay, here we go. All right, go ahead.
Well, thank you, Sue, so much. I really appreciate the invitation, and it's an honor to be able to be here and speak to all of you today. I'm going to give you a little bit of a perspective on the background in HIV treatment activism over the last 34 years. Try to apply that to the topics that you're talking about today here in terms of Hep B, with a particular emphasis on treatment and cure, but also I'm going to also mention in a bit the need for a vaccine for Hep C, which is curable. TAG works on HIV, tuberculosis, and viral hepatitis, and we've been around for 30 years. And here in the opening slide, I'm just showing you a little blast from the past, which is a picture of the BCG vaccine for tuberculosis, which was developed 100 years ago in France. And the point I'm trying to make with this slide is that research happens when there's a need in a country that's capable of doing research and it's funded and that there's political will. And with respect to tuberculosis, the vaccine was developed in France, and at that time, TB was one of the leading 5 killers of people in rich countries, and so there was a market need for it, and it's been around for 100 years. But it really only prevents TB among infants and very young children. It doesn't prevent adult tuberculosis. Next slide, please.
I can't see the slide. I can't see the slide.
Oh.
I can't see it.
Mark, can you see the slides?
No, I cannot.
Can the audience see the slides? Oh, they cannot see the slides. All right. I think we need IT help. I'm sharing the slides from my screen, but maybe my screen is not showing up on the main screen. Can somebody help with that? Or oh, hold on one second. Maybe I'm not sharing. Excuse me. Hold on. All right. I think I am sharing now.
Great.
Right. Okay. So
Is there a way to zoom up the slide size? There you go. Yeah. So I want to talk about some of the principles that have been really foundational for HIV treatment activism since the 80s, when the virus was first discovered in 83, AIDS was discovered in 81, there was no treatment. And nowadays there's an effective treatment, which is a lifelong regimen similar to Hep B, but there's no cure, and unlike Hep C, and there's no vaccine unlike Hep B. So building the evidence base for research activism is a really critical strategy that we've been using for our entire existence as a research movement. And so I'm just showing you an example from the 2010 TAG pipeline report, which is when we last covered Hep B as something that we were covering. And the problem with Hep B was that there wasn't a lot going on in the research space. And so we stopped covering it. And that might have been a mistake because we're not seeing enough progress in Hep B treatment, let alone in Hep B cure. And on the right, you can see a group of activists meeting at the EASL, European Association for the Study of the Liver, meeting in Barcelona in 2016. And they're demonstrating for lower prices for the direct-acting antiviral cures for Hep C. Next slide, please. So a key principle for the AIDS movement has been ever since 1983, when a group of really brave people with AIDS met in Denver in the United States and declared the Denver Principles, which include a demand for the engagement of all affected communities in research in every other aspect of their lives. So community engagement has been foundational for us. It's both right, it's ethical, and it's useful, sorry, and it helps to move science along faster. Next slide, please. So there's a whole bunch of different documents that show how people have the right to participate in medical research as more than trial participants, including the Denver Principles, the Declaration of Helsinki, and many others. It helps to ensure that research generates social value. It helps to ensure that research is ethical. Communities that feel connected to research are more likely to participate in studies. Researchers and communities can make strong alliances to build progress and secure funding. And later, when research proves something works, they can actually help to work towards access. They help to ensure that new technologies reach the people affected by a disease, and the communities who understand the science are better positioned to advocate for research with other funders, including government. They'll be also more willing to adopt new treatment and prevention and diagnostic technologies when they become available. And it helps to foster community ownership of research. And it provides, importantly, in this era of COVID-19, it provides a platform to address myths and disinformation about research and the process and the products. Next slide, please. So again, here's another example taken from COVID, but also from HIV research, it quotes from Dr. Tony Fauci in an article in the Wall Street Journal a couple of years ago. And as he pointed out, everything we do with every other pathogen spins off from things that we've learned from HIV. And the same is true of the research that's done in TB, in Hep B, and Hep C. We all learn from the pathogens that other people get, and we all learn from some of the breakthroughs that occur in other diseases. For example, the mRNA vaccines recently developed for COVID-19 are now being studied as a loader for HIV and for TB vaccines. Next slide, please. Here's a couple of TAG reports. One is from ACT UP and one is from TAG about how understanding and advocating for a comprehensive basic and clinical science research agenda is critical to our success as activists and into building those alliances with researchers that I mentioned before. Next slide, please. Back in 1992, researchers did not understand where HIV was living in the body of people that were living with HIV. And in order to build better treatments, they needed to understand this knowledge. And as a result, I joined a small basic science study that looked at my lymph nodes among 11 other people and looked for HIV within the lymph nodes to see if that's where it was hiding out from the body in the course of asymptomatic earlier HIV infection. And on the left, you can see a lymph node spotted with little white particles. Those little white particles are HIV virions. And that shows that even though I had a healthy CD4 T cell count, my immune system was still okay, that at that time my body was crammed with HIV. In other words, I was sure to progress to advanced disease if I didn't eventually go on effective treatment. And the slide on the right is a focus on a single T cell, the cell that HIV infects. And the little green particles are HIV particles or virions coming from out of that infected cell. Again, it shows And this was a time when many questioned whether HIV was indeed the cause of AIDS. This slide shows exactly how the cell infects and then kills the target cell, leading to the destruction of the immune system. So a lesson for Hep B is to learn how Hep B chronically lives in the body in order to figure out how to clear it out with treatment and ideally to cure it. Next slide, please. So here I'm just showing you the difference between my lymph node in 92 on the left and a similar lymph node in 1998 on the right. And the thing that had changed in those 4 years was that highly effective antiretroviral therapy had become available. They used the same stain and they could find hardly any HIV particles in my lymph node on the right, showing that the effective triple combination HIV treatment that I was receiving and had been on for 2 years had reduced HIV in my body to almost undetectable levels, although I was not cured and I'm still not cured. And 24 years later, I remain on a similar combination of therapy that's keeping my viral load undetectable. So again, this shows that scientific advances can come to help accelerate progress and allow people to live even with a chronic viral infection, even when it's not cured. Next slide, please. So here's a dramatic slide showing a demonstration at the National Institutes of Health campus in Bethesda, Maryland in May of 1990. And this shows a group of demonstrators from ACT UP using nonviolent smoke bombs, although they were very dramatic, to demand that the NIH allow people living with HIV and their advocates to take part in the research process in terms of designing, conducting, analyzing, and implementing the results of research. And the key point here is that we needed to form coalitions and communities that had the knowledge and the power to make demands of those who were conducting the science in order to change the science. And this led to a durable 32-year alliance between researchers such as Dr. Fauci and people like me who have been living with HIV since the mid-80s. Next slide, please. Another key strategy is to demonstrate when governments aren't doing what's necessary. And this slide shows a group of brave advocates from Treatment Action Campaign in Cape Town, South Africa in 2007. And they're demonstrating for community-based treatment and diagnosis for multi-drug resistant TB, which is a terrible disease in that country and affects many, many people that are living with HIV. And since this demonstration in 2007, South Africa has grown its HIV and TB programming to have the world's largest HIV treatment program and one of the most successful TB programs in a high-burden country with up-to-date treatment for multi-drug resistant disease. And so this demonstration, although it took a long time to reach success, has been successful in changing that country's health for its people living with HIV and TB. Next slide, please. So when I was talking to Sue and planning this talk, she was talking about how, and we just saw earlier from Nora's presentation, how unclear and inconsistent and how much gray area there is in the Hep B treatment guidelines currently. And so I thought about a campaign that TAG waged that took almost 20 years from its beginning to when it achieved success to change the treatment guidelines for HIV by insisting that they conduct science to find out through randomized controlled trials to find out when is the best time for people that are living with HIV to start highly active antiretroviral therapy. This therapy came out in 96. For 10 years, there was a lot of uncertainty about when to start this combination therapy. In 2007, after a decade of advocacy, NIH started funding the strategic timing of ART, or the START study. There's a misprint on there that says SMART. And that study compared immediate HIV treatment to waiting until the CD4 count dropped to a danger zone. Within 8 years, the study, which was a giant multi-country, multi-thousand person study, showed that it's best for everyone to immediately begin ART for HIV infection, regardless of their CD4 T cell count or immune status. And the very next year, the World Health Organization recommended HIV treatment for all. As a result of the change in guidelines that came out of this and a couple of other trials, by 2022, this year, 28.5 million of the world's 38.5 million people living with HIV are now receiving life-saving HIV combination therapy. And I think this is a really clear example of something the Hep B field needs, which is to demand that that uncertainty in the treatment guidelines be changed by doing randomized and controlled clinical trials to define when is the best time to treat Hep B, or whether in fact it's actually best to treat everybody living with Hep B and to figure out a way to deliver that cheaply and ethically and equitably to people all over the world. So these are just some of examples of how over the last 3 decades, AIDS activists have worked to advance the field of HIV, a pathogen that wasn't even discovered until 1983. And I do want to, can we have the next slide, please? I do want to end on a personal note, which is that I too have been infected with hepatitis B. I got infected with it in 1980, and I was very lucky to have a strong immune system at that point, and I was able to clear the virus, which again proves that biologically it's possible to cure Hep B. Very, very few people have been able to clear human immunodeficiency virus because it integrates into the host cell DNA. But since we know that some people are able to clear Hep B, we know in theory the immune system can handle it if you give it enough assistance with chemotherapy. And so I'd like to thank the organizers of the meeting. I'd like to thank Sue for a really useful conversation to help prepare for this. And I'd like to thank TAG's Hepatitis C Community Engagement Officer, Joelle Duntio Ofimbidem, for helping to put together this talk and for all the great work that she does. Thank you.
Thank you, Mark, for a really powerful and impactful talk and walking us through what's happened with HIV, because I think there are so many lessons to be learned from that story. And also thank you for sharing your own story. I think that will inspire many of us living with hepatitis B to kind of think differently about our own treatment and care. So I'm going to pass it back to my co-chair, Philippa, who will kick off our discussion. There are some, let me just encourage everybody, if you can get on the platform, there's a number of questions that have already been posed that have been answered by the speakers, and you can also participate in the discussion. And just so you know, these questions and answers and the discussion will remain on the platform for 3 months, so you can continue to have this discussion even if the session is not live.
Great, thanks very much. And I think this was a really terrific 360 degrees perspective, hearing from Ethiopia, China, the United States, and then the perspective from the community and the patient from you both. And I think always to hear of the lessons to be learned from HIV and how we can build on that. So I'm going to start, and we've been given, I think, permission to extend beyond 6 o'clock for the discussion. So I would like to start with a general question, which I'm going to ask to each of the speakers and to request a very short response. And I think in all the talks, the main challenges have been flagged, the issue of community awareness, provider awareness, addressing national funding, addressing the price reductions, both drugs and diagnostics, the issue of guidelines and service delivery. And all of the different perspectives from particularly at the country level have covered some of those issues, but with still more challenges. So starting with Helmikel, from Ethiopia, you flagged the very low uptake. A question to you is really about the guidelines and the eligibility for treatment. Do you see this as the most, or one of the most important things to address, to expand and simplify? How far would you wish to go? And also on service delivery models. You at the moment have started in sort of hospital setting. Where do you see this going? How much can you leverage on the HIV infrastructure? So if you could focus on those 2 key issues with a short 1-minute response. Thank you.
So while Helmikel is thinking, I wanted to just have Philip also just talk real quick about WHO updating their guidelines so people kind of know the broad context.
Fine. Well, maybe just to start with the laying out the framework for the way ahead, much as we've done for the Hep C guidelines, with starting with stakeholder consultations and prioritizing what are the key questions. The same process is now being gone through for hepatitis B. So I think priority number one will be on expanding the eligibility criteria. And this conversation is not just beginning. This has been going on for some 2 years. And the low-hanging fruit is really on the non-invasive tests, how we categorize cirrhosis, and lowering the APRI threshold for the diagnosis of cirrhosis. So no further tests needed if APRI is less than or greater than 1.5 or 1. That would be a case for initiating treatment. In terms of the Hep B DNA threshold, we were still at 20,000. Clearly, there's an opportunity to now relook at that and expand. Those were the two main areas. The other area we're considering is on prevention of mother-to-child transmission. The use of antivirals was very much in the context of having a Hep B DNA greater than 200,000. That is becoming really an impediment given the limited access, and really the relaxation of that, at least in some settings, to be able to just treat. And then looking also, as we did for hepatitis C, on the use of point-of-care platforms. There's less evidence, but that would be another area. And then simplified service delivery with some different approaches. So that's where we're starting from. But I think this is an opportunity to hear from all of you as to where you see the priorities in terms of eligibility and guidelines and service delivery. Michael, please.
Thanks so much, Dr. Philippa. This is a great chance for me to speak on this summit and representing the low-income settings. When we see, as I've tried to see the low-income settings, there are many gaps, starting from the screening program, diagnosis of these patients, research gaps, and then accessing the diagnosis and the treatment. The WHO has been key in supporting us in different guidelines. And as I've stated, the low-income settings cannot rely on the EASL or the ACLD guideline, and they depend on the WHO guideline. And in the diagnostics, still, if we rely based on the nucleic acid-based tests for the hepatitis B, which have not been feasible up to now, we cannot continue with this regard to reach to the elimination. That's why point-of-care tests like what you have done for hepatitis C, point-of-care tests that could rely on a short period of time and also less expensive means of treatment could help us to reach many patients. Probably naming some tests like validation of the gene experts could probably help us. And then with this, probably we can leverage the resources that we are using for tuberculosis, because the tuberculosis program has both many gene expert machines. And if guidelines can support us, then we can use those machines probably to use the hepatitis B viral DNA, and which can also measure the TB with the same machine that had been used for the TB, and with the available machine which is currently used for the TB programs, which have been bought, because TB has a big support from different funds. But the hepatitis B has no fund, and we find patients, we send them for nucleic acid tests, which are expensive, not available in the countries, sent abroad, and incurs many costs, and patients and the physicians and the clinicians come with a big disparity and with despair, because they cannot treat based on these viral tests. And the other thing is also in the treatment, probably this needs a system-based approach. Probably a big lesson is from the HIV. We know how many patients are on HIV, how many patients are on 1A therapy, and countries can probably know the number of patients who are on treatment or who are diagnosed with HIV. But for hepatitis B, we don't have such wide-scale screening strategies, because the countries or the Ministry of Health cannot access or cannot support wide-scale screening or survey programs. And all those studies are based on institutional level, and we don't know the data, how many patients are really on or high spots, countries, high spots with hepatitis B, and we cannot access those patients. But once we are able to access and screen with low cost methods, and then we can probably reach these patients. And as you have mentioned, simplified treatment guidelines based on the African threshold can help us reach these targets.
Great, thank you so much for being so succinct. So I'm now just going to move to China and to Fushan. China has addressed many of the initial challenges, and great to see the price reductions in. Great to see the price reductions in with tenofovir, but you highlighted that still the testing and treatment coverage is low. What is the barrier there? Is it the service delivery models? Is it lack of community awareness? What would you see as the priority going forward, Fushan?
Thank you, Philippa. And I think it is an excellent question. And as other countries, we have the low screening rate and treatment rate in China. And we people know that without the higher treatment rate, we cannot achieve the 2030 goal, obviously. And the issue in China, I think we have the very, good availability of testing. Testing can be provided everywhere. So in any hospital, it's very easy. We have very low drug price. So the issue is, I think we have three issues. Number one, we don't have the national-wide policy to implement the screening. We don't have the higher awareness. People, even they have their chronic hepatitis infection, but they don't, understand that it will maybe develop into the cirrhosis or HCC in the future, possible. But people still, think they can wait. So I think it's the issue people don't know, have the better early treatment will have the benefit and prevent the future early deaths of the severe disease. So we have to improve the awareness among the population. I think the third one is we need to have the more clear and simplified guideline to give people their instruction to have people participate in the testing and then link to the point of care. So these, I think, are the three most priority questions and the urgent need in China. Over. Thank you.
Thank you so much, Fushan. And I'm now going to move swiftly to Nora to ask a question about the guideline simplification. I recall on previous talks where you've talked about these indeterminates, that many of them don't progress, and that I'd always sensed a note of caution in your promotion of expanding the criteria. And would expanding the criteria address the fact that even those who do meet the eligibility criteria in your context, 20 to 30% were not starting treatment? So simply expanding the criteria is not necessarily the solution. Over to you, Nora.
Yeah, I think it's hard to note for that 1/3 that's not on treatment, why they're not on treatment, right? We know it's maybe linked with them getting access to a specialist, but I think rather than expanding specialists, I think thinking about how do we empower kind of primary care to be able to do more of this total management of Hep B is something of importance, I think, in a high income country, is that you have to expand capacity. And in that regard, I think the simpler we make the decisions around treatment, the better, because primary care doctors are very busy. And I think they need very straightforward kind of approaches. But I'm not somebody, I just put it in the chat, I'm not somebody who believes in treating everybody with virus. I'm not, because I don't think the data support that. And I think you're alluding to that actually, Philippa, but I do think that we can make it less complicated because we have all these this level of HBV DNA, this level of ALT, that does complicate an approach. So I do feel we could simplify it by, having really just very simple categories of this level of ALT, this level of HBV DNA, treat, without a lot of differences between e antigen positive and negative, and without this need for really being very strict. I want to bring the thresholds down so that more people will be eligible. But that being said, That doesn't mean everybody's going to be treated. I still think we should have a threshold for virus, because I think that really is best supported by data, that a level of virus of I think it's around 10,000. Actually, that's the number, is really one in which you really want to be confidently treating patients. I don't know where we came up with 20,000. That's kind of very arbitrary. But, I think around 10 to the fourth is the number in which we have very strong data that people should be treated. So maybe moving towards focusing on that group, making sure those individuals are getting onto treatment, regardless of ALT level to some extent. And then really thinking a little bit more selectively about people that are under that value. And then using, I think that kind of simplification is where we're going. But I'm not, I think we want to make it easy for our physicians, right? And also a little bit easier for patients too, to understand how we're thinking about treatment.
Great. Thanks, Nora. I just want to add in one thing that Mark had mentioned that I don't think we're really in your slides, but I think the idea and the knowledge that we have now about Hep B virus integrating into the DNA. And I do think Mark's slides really illustrated beautifully that there are some things happening immunologically that are not necessarily measured or even captured in our current guidelines. And as somebody living with hepatitis B, that actually scares me, that oncogenic potential. We know that you can have cancer without having cirrhosis, having Hep B. And I just feel like as a patient, those are concerns that patients have. Just as a side note, I know Mark was sharing, I'm somebody who lives in that gray zone. My viral load has been hovering around 2000. And I have seen the data on DNA integration, and it was enough to get me to start. And my hepatologist actually have been telling me to hurry up and start, even though I don't fall into the AASLD guidelines. So I think there's a lot of urgency around this issue around patients as we hear more research that is not necessarily reflected in the guidelines at this point, that it's important for us to have these conversations with patients and not necessarily just wait for the cures to come or new treatments to come, but it's helpful if we are also clued into what the newest research is, coming out about the virus, learning about the virus more. So just want to throw that to everybody out there. If Mark wants to do this, this will have to be our last question. We actually have to move on to our next session. I want to encourage people to get on the platform and have this discussion. This is obviously, we could talk about this for a really long time, and I think it's very important. And I hope that we can have this discussion as guidelines are being developed, whether it's WHO, AASLD, EASL. Please make sure you include the voice of people living with hepatitis. And I'll leave it at that and pass it on to you guys if you have some last comments on that. Maybe Mark and Nora, maybe, or anybody else.
Okay, I think let me add my voice to this, Sue. That this reiterates what I said earlier concerning patient empowerment as a key factor in improving access to care. So it's important that so even when treatment is improved and the patient there's no awareness and the patient is not really empowered, they can't even access the care. So it's both ways, the structural and then maybe system. So for example, low middle income countries, decentralization of services is very, very, very crucial in improving access to care, but patient empowerment, increased awareness is very important in improving access to care, especially in low middle income countries.
Great. I'm actually going to let Mark have the last comment, if that's okay. Anybody else who wanted to comment, if you don't mind commenting in the chat, that way we can move to our next session. Go ahead, Mark.
Thanks, Sue. You have inspired me to call for randomized control studies of when to start treatment for Hep B. If you think about the global toll of the disease and the burden of lives either lost or cut short or unable to work and contribute economically as they should, the cost benefit of using cheap generic treatments that can control Hep B to mitigate the disease burden, and also FYI could also prevent onward transmission, i.e. sort of test and treat approach. Although it will be costly, and although primary care is not very good at giving anti-infectives to people that are chronically infected with infectious diseases, we do have 30 years of experience from the HIV space in doing this. And I would like to add TAG as a supporter of all of your efforts to help bring Hep B under control and to speed the research to end the disease. And I really enjoyed participating, and I feel that we should work together. Thank you.
Oh, I love that. Thanks, Mark. That's a great next step, and we definitely look forward to working with TAGs. So once again, thank you, everybody. Thank you especially to the speakers for making the time to join us. This was a very productive discussion, and we hope to continue it in many further venues. Thanks again.
Thank you.
Be well.